So welcome and thank you for joining us today for the meeting of the New York City Health and Hospitals Board of Directors. Today's meeting is officially called to order. Please note for the record, Scott French is representing Stephen Banks, Dr. Michelle Morse representing Dr. Dave Shoxey, and Philip Waddle is representing Deputy Mayor Melanie Hartzog, all in a voting capacity. Next on the agenda is the adoption of the minutes for the board meeting held March 25th, 2021. Are there any questions or comments or changes? Okay, so I'm gonna poll all members for a vote. Dr. Katz?
Yes.
Dr. Calamia?
Yes.
Dr. Morse?
Yes.
Thank you. Dr. Harrison?
Yes.
Thank you. Philip Waddle? Scott French? Barbara Lowe?
Yes.
Thank you. Robert Nolan?
Yes.
Sally Hernandez Piñero?
Yes.
Rita Juan? Rita? Danielski Peñamora? Danielski? And Anita Kawatra?
Yes.
See you there. Thank you. And Jose Pagan, yes. So the minutes have been adopted. During the executive session, the board received and approved oral and written governing body submissions from NYC H&H Metropolitan. The board received and approved governing body written submission of NYC Health and Hospitals East New York Diagnostic and Treatment Gotham Center 2020 Performance Improvement Plan and Evaluation. And the board also received and approved semi-annual governing body reports. These are written submissions from NYC Health and Hospitals Coney Island and Seaview Nursing and Rehabilitation Center. We convened the second of 5 2021 annual public meetings for the Borough of Manhattan on Tuesday, April 20th. The remaining meetings will convene at 6 p.m. on the dates noted below, and a determination would be made at a later date as to whether they will be in person or virtual. So Queens will be Tuesday, May 25th, the Bronx will be Tuesday, June 8th, and Brooklyn Tuesday, June 15th. Vendex approvals. Since we began the process of approving contracts prior to Vendex approvals, there are 10 items on today's agenda requiring Vendex approval, of which eight have approval. There are 5 items from previous board meetings pending Vendex approval. Since we last met, we have received 2 Vendex approvals. We will continue to notify the board as outstanding Vendex approvals are received. So I'm going to move to the resolutions next, and then we'll do the president's report. So it's item number 2. Dr. Calamia, you want to read the resolution? You're on mute.
Apologies there.
There we go.
So, thank you. The New York City Health and Hospitals Corporation, the system, to amend 6 agreements for neighboring canvassing as part of the system's response to COVID-19 pandemic with AM Trace LLC, Full Contact Communications LLC, Mosaic Sales Solutions, Reserve, Connective Strategies Associates Inc., and Janoon Inc., the vendors, previously signed under emergency authority to increase total spending authority from $20 million to $60 million. This was discussed at our joint medical and professional affairs and information technology committee for presentation to the full board.
All right. Well, thank you all. This is Ted speaking here. Thank you for having me today. And I will go through the presentation to give the background for this resolution. I'm joined here today, I believe, virtually by Jonathan Viger is on my team. Okay, very good. He'll join me for the Q&A at the end. So to jump right in here, the background is that one of the things that we do through Test and Trace, and in particular through this canvassing effort, is extensive outreach. The outreach is focused both on educating people around testing and now the vaccination effort, but importantly, the outreach gives us a way to now directly connect people to make vaccine appointments. That means that when we have the person in front of them, they leave that interaction with a physical appointment to come and get the vaccine themselves. This is something we can uniquely do through the canvassing effort. It's been very important to getting New Yorkers vaccinated that we want to continue to do here. By further way of background, the 6 firms that we have selected here that we've been funding so far were selected through an RFP that was conducted, and then these 6 firms were selected. Next slide, please. Okay. So the approval request for today is to increase the not to exceed amount for these contracts. There's currently, though, one of the key reasons why we want to continue the canvassing effort is it allows us to get into the communities that are the hardest to oftentimes reach and the hardest to engage. In particular, the Mayor's Task Force on Racial Inclusion and Equity. This gives us a line of sight and an ability to directly address health disparities through being able to offer vaccines with concrete appointments at the end of each of the interactions we have with people in these communities. What we'll be able to do, what you know you're going to be buying here, is we're going to be able to do more than 1,000 shifts a day. And just to give an overall backdrop here, for the $20 million not to exceed that we currently have, going up to the $60 million not to exceed, we're going to have more than 3 times the ability to do more shifts. So we do gain economies of scale through increasing this effort in terms of the overall number of shifts we'll be able to do. Next slide, please. Okay. In terms of financial considerations, the backdrop to how this is financed is H&H has, with OMB, a memorandum of understanding. That enables us to access and use grant dollars predominantly for the testing effort through a CDC grant, and for the Canvas vaccine effort through FEMA. This covers this not to exceed of $60 million will cover the canvassing effort through September of this year. Okay. Next slide, please. So I'll take to go through what we've done so far to give you a sense of the key performance indicators for the canvassing effort. Want to be clear up front that all of the current performance for the vendors so far has been considered satisfactory. Now, what we've done more than 547,000 commitments to getting tested through conversations around testing that we've had. We've distributed more than 7 million masks. Very importantly, we've, for 70,000 New Yorkers, actually done the thing I described, where we actually schedule your vaccine appointment, directly schedule it for you as part of that interaction, with the highest concentration of vaccine appointments made in our at-risk communities, predominantly the highest concentration in our task force for racial inclusion and equity communities. If we are able to go to a not to exceed of $60 million, we'll be able to do 30,000 more vaccine appointments each week, with the majority being in these same communities, which we know have some of our most vulnerable populations, most vulnerable New Yorkers. In terms of what we've been able to accomplish for outcomes, when we have our canvassing effort, we see a 15% decrease in no-show rates for getting vaccinated. We also see a 25% increase in our ability to get NYCHA residents vaccinated through this effort. The final thing I'll mention is that on this slide, more than half of all of our staff hirings to date has been from these exact neighborhoods that we want to serve through this effort, our task force on racial inclusion and equity neighborhoods. Next slide, please. Okay. So in terms of an overview of the procurement to date, there was an RFP that was posted to the city record with content approved by our CRC committee here. 16 firms responded, 6 were selected. They are AM LLC, Full Contact, Mosaic, Reserve, Connective Strategies, and Janoon. We currently have a not to exceed of $20 million with these 6 firms. This proposal, this resolution, would be to increase the not to exceed to $60 million. Next slide, please. In terms of the terms and assignment of work, importantly, work is assigned to each of these firms based on things like geography and languages that these firms speak that our communities speak. The pricing that you see here on this slide includes transportation costs, supervision costs, the actual staff costs, of course, and PPE costs. Importantly, the contracts here are under the direct supervision of the Senior Vice President for Ambulatory Care and Population Health, and shifts are always given at the discretion of the contract manager. Next slide, please. For a recap of the procurement process, on the right-hand side of this slide, I lay out for you the evaluation committee, followed by the evaluation criteria. Then on the left-hand side, you can see the actual firms that have been selected, that were selected through the RFP to date. I want to spend a couple minutes to talk about the MWBE status of each of these firms. First off, Janoon is a current MWBE. Connective Strategy Associates is a current MWBE. Mosaic Sales Solutions is a firm that initially was granted a waiver, but now has committed to 30% MWBE, and our program team is working with the vendor on the selection of the subcontractor in order to achieve this. Reserve has committed to a 30% MWBE, and with spending to date is 55% MWBE subcontractor payments. AM LLC also committed to 30%. And to date, they've only, if you look, they've only spent or only had the price of around $50,000 from a total payments of 1.1 million. So they have a ways to go in terms of the overall payment that they will be receiving. So that's why their number there is lower in terms of the MWB payments so far. But our program team is not missing a beat and is working very closely to them to ensure that they achieve the 30% commitment that they've been clear in making. Full Contact, previously known as BMG, also is committed to 30%, and with payments to date, 27% have been to an MWB subcontractor. Next slide, please, and here's the resolution. I'd be happy to read it again for the board, or we can go to questions.
No, question like this. Any?
I have a question.
Yes, Sally.
Yeah, two quick questions. One, the drawdowns, the payments to the firms have been a percentage of the total allocated to the firms based on their performance.
Mhm.
And I just want to make sure that because we get money from OMB and that takes time, and then we pay out to the firms, that there are no cash flow crunches created for the firms. So do you think that the money is flowing quickly enough to them?
Yes, I appreciate the question. So just to clarify for the board how the cash flow works, once a payment is submitted to accounts payable, we are giving the firms, typically paying the firms 1 week later.
Okay, all right, that's great.
Mhm.
Thank you.
Thank you. Any other questions from the board members?
I have a question. Or
Go ahead.
yeah.
please.
Thank you, Mr. Chair. I just want to say, how important this work is, and thank you, Ted, and your team for leading this effort. And I'm particularly impressed with the accomplishment and how the focus on the vulnerable communities that have been affected disproportionately by COVID. You are having this very active outreach. So thank you. I also would like to commend your team as well as Daniel Devari's team for ensuring that even though, during the emergency, we have to mobilize very quickly and ensure that we are able to provide the services that are required for our patients and our communities, that now that we are going through the regular process, you were able to go back and look at some of the contracting arrangement, particularly Mosaic Sales Solution. It had achieved a waiver in the past, and now they are committed to the 30%. I think I just want to commend both your team and you, as well as Danielle Divari and her team for achieving doing that. And I also appreciated your comments and looking closely at the spend of these companies and identifying how AM LLC has a lot of ways to go because they only are right now at 4%, and it's very reassuring that the program team is working with them to ensure that they meet their contract arrangements that has been established. So I just want to thank you, and again, Daniel Deveri, for your work and all that you're doing for our patients and our communities.
Thank you, Fanny.
Thank you.
Can I ask just one other question?
Go ahead.
I'm
please.
sorry.
Sally Hernandez has a
I'm
question.
sorry, just two of your contractors, the costs they get per 8-hour shift depends on deployment of staff. Does that mean the more staff you need, the lower their rate goes?
Correct.
Thank you for the clarification. Any other questions?
No, I'd just like to say that the job that you've done from day one has been absolutely fantastic. I know every day you're expanding into new areas and new communities, and it takes money to expand into new areas and communities. It's a big city. So I certainly will support this, because I think whatever amount of money that you feel that you need in order to provide services for all New Yorkers is essential. So I will support that based on your history of being everywhere in every neighborhood as much as you can with your wonderful staff.
Thank you. I appreciate that.
Thank you, Mr. Owen. Okay, so
This
Let me
is
then
Michelle
call
Morse.
for a
I
vote.
have one question.
Go,
Can I jump in?
go ahead.
Okay,
Yes,
great.
please.
Thanks so much. I was trying to use the raise hand function, but it may not be very visible, is what I'm realizing. Thanks so much, Dr. Long, for the presentation and for your hard work. The question I had is because we're in yet another phase of the vaccine campaign, and I know this is focused on T2. I'm just curious if you could say a little bit more about how you're thinking about focusing the efforts. The tree neighborhoods, as you mentioned, are about half of the city. And so I'm wondering if you're thinking about focusing even further beyond the tree neighborhoods.
Yep, and the answer to that is 100% yes. So the way that we look at where we need to apply any of our resources, be it our mobile testing fleet, our moving around where we do our vaccine pop-ups, or our canvassing effort, is based on where we ascertain there to be need. And we do that collaboratively with your team at the Department of Health. We see areas where we know we need to deploy our resources more forthrightly. We do that. And it all works in concert together. So a lot of times we may deploy our canvassers in areas where we are setting up a pop-up site in a niche of development, for example, and that enables us to make the direct connection with people in that development to where they can go, oftentimes downstairs to get the vaccine. The way we select where we're going to go next is collaboratively together, looking at factors, as you know, where are the vaccination rates lower, where are our communities that have really been the most impacted by COVID, and where are we seeing now in terms of where the pandemic is going in our communities. So I think, as Bob Nolan was saying, we really are everywhere, but we focus ourselves where we need to be based on need.
Thank you. Okay, so let me then call for a vote on the resolution. Dr. Katz?
Yes.
Dr. Calamia?
Yes.
Thank you. Dr. Morse?
Yes.
Thank you. Dr. Harrison?
Yes.
Thank you. Philip Weddle?
Yes.
Thank you, Philip. Scott French? Barbara Lowe?
Yes.
Robert Nolan?
Yes.
Sally Hernandez Pinheiro?
Yes.
Frida Wang? Benioski Peña Mora?
Yes.
Anita Kawatra?
Yes.
Thank you. And Jose Pagan, yes. So the resolution is approved. Thank you so much, Dr. Long, for all you do and for deploying. What did you deploy this week? The mini buses and all of that?
Yes,
Mobile
amazing.
Yes,
Amazing,
the
yeah.
three new minibuses.
Thank you. I mean, it's always very encouraging and when I think we're doing a lot, then I see all the work that happens and I go like, wow, they thought about that too. So thank you, Ted.
Thank you very much. Thank you, everybody.
Thank you.
Okay, so the next one is number 3 in the agenda, Dr. Peña Mora. I don't see him there.
Yeah, he's there. I see his name.
He's on mute.
Benny, you're on mute.
Okay, I apologize. So sorry that I just jumping. It's for the contract. The resolution that we're asking is for authorizing the New York City Health and Hospital Corporation, the system, to execute job order contracts, jobs, with 3 firms: Walmart Construction Inc., BA Global Construction Inc., and Carefree Improvements Inc., the contractors that were selected through the system's public bid process to provide general construction services and on as needed basis at various facilities throughout the system, with each contract to be for a term of 2 years for an amount not to exceed $10 million for each contract, for a total authorized value of $30 million.
Good afternoon. Can you hear me now?
Yes.
Yes.
Good afternoon. This is Christine Flaherty, Senior Vice President, Office of Facilities Development. I'm joined by Oscar Gonzalez, AVP of Capital Development Group. Our job order contracting program is one in which we have construction contracts that are awarded based on a public bid. And those contracts have an itemized catalog, which allows us to swiftly go into construction once we know the scope of our work for general construction, smaller scale projects, and urgent projects. These procurements include Operating Procedures 100-5, and we have current GC contracts in place today that were awarded in 2019, and they're set to expire in June of 2021. Just a little more on the job order contracting structure. The itemized catalog breakdown is based upon industry standard pricing from RS Means, as well as the Construction Institute, published by Engineering News Record. These contracts are for system-wide services across all of our facilities based on need. Next slide, please. This shows you the current general contractors that we have in place across our system. There are 3 firms that are used heavily throughout our systems. This shows you the value of the work issued to date, what is remaining in their contract, as well as the MWBE spend across those 3 contracts. For this solicitation that happened in 2019, 6 firms had bid against these 3 contracts. Next slide. The procurement that occurred in February was bid out, and bids were opened on the 24th, 25th, and 26th this year for 3 contracts of $10 million each for general contract construction services. What's exciting to see is we received 17 bids from 17 different firms, so that shows that we have an increase in competition for our system, which is always good. The first bid opening award goes to Volmar Construction. They were the lowest responsible bidder. We had 17 bids submitted. Their max evaluation for the city is satisfactory. And Volmar has a history working for health and hospitals. And within our user rating system, they had a 96.5% across 4 facilities on 20 projects. BA Global is a relatively new firm to both the public sector as well as H&H. They were the lowest responsible bidder for GC2. There were 11 bids submitted for that opening, and they had excellent references for private referrals, as well as they are currently starting up a new project at Woodhull, which is a little too early to do an evaluation because they're just mobilizing now. It looks positive thus far. Carefree Improvements at MBE was the lowest responsible bidder for GC3. 9 bids for that were submitted. They didn't have any max evaluations in the last 3 years. Their user rating within our system is 87%. And more recently, we look at their track record and working closely with Carefree, their improvement ratings has increased in the last 3 years. We had realized we got some great feedback, and we've been working and partnering with this firm to mentor them. And we've seen improved performance on the work that they're doing across our system. So we're excited about them joining this procurement again. The next slide shows the utilization plans for the 3 firms. All firms met or exceeded the 30% goal. BA Global actually has their own MWBE certification pending with the city. And so they actually could end up with 100% MWBE utilization, but here we're noting the 45%, which are the subcontractors they've identified for their GC work. Volmar has a 31% plan, which all of their subcontractors are listed in this. And Carefree is an MBE that also has a subcontracting plan of 10%, and they self-perform 60% of the work, giving a total effective MWBE utilization of 70%. Next slide. And the last slide is the resolution for these 3 GC contracts that support our system. Happy to take any questions.
Thank you. Any questions, Sally?
Christine, I was looking at your financing, the section on financing, and it talks about the facilities establish the funding sources, and they have different sources they could use. Do you have a pipeline of contracts that they'll be coming for funding, or is it like de novo or a combination?
So it's typically a combination. Sometimes our facilities may have grant opportunities that present itself. They may have relatively very small, urgent, expense-funded work that's needed. And then we also have our capital pipeline, and if the projects are in small value, we may opt to utilize capital funding for specific capital projects. So
But is this a new 30 million or 30 million that is tapped at the facilities? That's what I'm confused about.
the funding source is going to vary on a per project basis.
Right.
We're not able to start any project without full funding in place and signed off by finance. So it will depend on the project in that moment, but working closely with supply chain and finance and utilizing our PeopleSoft system, we're able to very clearly identify the funding source before anything can start.
Okay, thank you.
Thank you. Any other questions from board members? Okay, so I would like to then call for a vote. Dr. Katz,
Yes.
Dr. Calamia,
Yes.
Dr. Morse,
Yes.
Dr. Harrison,
Yes.
Mr. Waddle, Barbara Lowe, Robert Nolan. He stepped out for a second. Sally Hernandez Piñero,
Yes.
Frida Wang, Feñoski Peñamora,
Yes.
Anita Kawatra.
Yes.
Thank you. And Jose Pagan, yes. So the resolution passes. Let's move to the next
Thank
one.
you.
Thank you. Dr. Peñamora, you have the next one, number 4.
Dr. Calamir, can you please recuse on the record? He's gone. He just left.
Just left, yeah. Can you read the resolution,
Yeah.
Feñoski?
Okay, thank you,
Right.
Mr. Chair. The resolution requested is authorizing New York City Health and Hospitals Corporation, the system, to sign a 3-year best interest renewal contract with Change Healthcare Incorporated, the vendor, for an enterprise-wide radiology diagnostic management solution with 2 one-year options to renew the contract, exercisable only by the system and with the total cost of the contract over its full potential 5-year term of $15,875,046 with a 10% contingency of $1,587,505 for a total expense not to exceed $70,462,551.
Thank you.
Good afternoon. This is Dr. Allen. I will be opening up the presentation. I want to set the stage. Over the previous 5 years, New York City Health and Hospitals radiology directors have worked with Change Healthcare, previously known as McKesson Technologies, to establish an enterprise-wide, single-vendor imaging system for the H&H enterprise, which is a state-of-the-art among healthcare systems. The enterprise-wide imaging system, which has been built by Change Healthcare for New York City Health and Hospitals, includes a number of items, one of which is the single PACS system for the non-clinicians in the room. A PACS system is the picture archiving and communication system, which provides economical storage, retrieval, management, distribution, and presentation of medical images. And if you've noticed, the images today are digital files as opposed to the old-fashioned X-rays. We will present to you the need to extend this contract in order to put in place enterprise-wide upgrades, along with training and knowledge transfer to our own staff. We will also present to you why going out to bid for a new vendor with the resultant deconstruction of these gains achieved over the past 5 years would be prohibitive, not just in financial investments lost and new financial investments required, but also would present to New York City Health and Hospitals a tremendous setback in terms of losing our place among New York City healthcare systems in the radiology universal imaging sphere. This would result in the loss of 5 years' worth of labor, and technological progress, plus the loss of an additional 2 years for a potential new vendor to lay the groundwork to rebuild that which has already been built by Change Healthcare. I'd like to now turn the presentation over to our team, which consists of David Shee, Senior AVP within MMPA for Radiology Services, Dr. Al Garofalo, Senior AVP in EITS, Keith Talbot, Esquire, the Office of Legal Affairs, Joe Wilson from the Office of Supply Chain and Purchasing, and Dr. Michael Ambrosino, who's here virtually, co-chair of the Radiology Directors Council here at H&H and chair of radiology at Bellevue Hospital. Next slide. Second slide, if we can go back to the second slide. So, okay,
Slide 3.
next slide, Dave.
Thank you. Under the system's procurement operating procedure 100-5, where it is in the system's best interest and where supported by a cost-benefit analysis, the system may renew a contract rather than re-procure. The vendor solution is providing substantial benefits through its software and services and continues to perform well. There is a lack of opportunity in the market were the system to switch vendors. Market analysis shows no price savings to be gained based on industry pricing benchmarks. The price for the services has not increased on a per unit basis since being competitively procured 5 years ago. And Change Healthcare is one of the top providers of enterprise imaging solutions, and we have colleagues in the New York area such as Northwell and Montefiore who take advantage of the same solution.
So I know Dr. Allen spoke about this a little bit prior, the necessity of switching to vendors and the impact. The deconstruction, the next slide, please? The deconstruction of the gains achieved over the prior 5 years would include a new single enterprise PAC system, a vendor-neutral archive system for imaging, a single enterprise work list, a single clinical viewer, a full integration of the imaging within the EMR, a fully integrated dictation system, an enterprise-wide business intelligence and analytics system, and a concierge system for delivering of critical results to the ordering provider. Not to mention the loss of labor and investments. Just imagine having to redo 18 million images that we've already imported into our new EMR and our new PACS. Migration of all images that contain pertinent markings like mammographies, and critical teaching images that have to be manually QA'd as they're migrated into a new system. Reconfiguring a work list for the radiologist, for the subspecialists like the mammographers again, and the neuroradiologist. That process alone took over 2.5 years. The reconfiguring of over 800 modalities to either into the new system if we went to a new system, and inclusive of all the vendors we'd have to get, like Phyllis and GE back on site. Retraining of over 180 radiologists, technologists, PACS administrators, and even the end users like the providers. In the end, excluding the resource, time, and effort, it would cost approximately an additional $16 million. Next slide, please. Okay, this slide really is quickly to go over the market share. On your left is the share Change Health is occupying right now in the current playground. In the middle is the lead, and they are again the market lead. And on the right-hand side is what they call the class rating, which is the evaluation. And again, Change Health is leading the pack. Next slide, please. This quickly is a comparison of the accomplishments, where we were and where we are now over the last 5 years. And the next slide will give you another appreciation of it. Thank you. So what do we got to look forward for the next 5 years and beyond? Well, the integration of a cancer screening system known as DynaCAD, which is for breast and lung, the EMR and VNA integration for all our third-party systems. And I've got some information I want to go over that with in a second. So let me give you an example of what the VNA can hold. The VNA holds what we call all of the other third-party imaging systems, like ophthalmology, OBGYN, GI, point-of-care systems. And currently, we are in the process of importing over 90,000 ophthalmology images, 75,000 OBGYN images, 50,000 point-of-care images, over 25,000 GI and pulmonary images, and over 50,000 cardiology images. If we had to go to a new vendor, either we'd have to maintain this VNA with McKesson, or we'd have to go through the same process all over again with a new vendor. Other enhancements we're looking forward to with Change Health is advanced voice and collaboration tools, advanced clinical viewers for the providers, the end users, and advanced artificial intelligence. Next slide.
Keith?
Thank you. Good afternoon. My name is Keith Halby, Office of Legal Affairs. I lead our vendor diversity program for our system. I discussed the MWBE plan with Change Healthcare and reviewed it, and Change Healthcare had an opportunity under our Pride agreement for concierge services. Those were their only bucket of subcontracting at the time, and that was subcontracted to an MWBE named Atria Consulting. We have subsequently insourced that work to our team, and now the only remaining bucket of subcontracting opportunity is consulting work, essentially, program management. And that again represents now a 10% opportunity, 10% of the total value of the contract. So the only portion that is available for subcontracting under the current agreement scope of work is being subcontracted to a certified MWBE.
Thank you.
Next slide.
I'll do the diversity slide.
Okay, great.
Yeah. So the outsourcing to Atria is actually a women's owned business enterprise. So it's a 10% of the spend will be to a WBE organization that we're outsourcing for program management. Doing a deeper dive into the diversity of Change Healthcare, they were kind enough to send us their most recent data from March of 2021. Their worldwide employment is a little over 14,000. Their US employment is 13,133. Their US data, 71% of all employees are women, and 34% of all employees are persons of color. The breakdown as it is on the slide is 17% Black, 9% Latinx, 8% Asian, 2% of their employees are of 2 or more races, and 1% fall in the Native American, Alaska Native, or Native Hawaiian Pacific Islander. They have a director of diversity and inclusion. They actually have a supplier code of conduct where they have a supplier diversity initiative. They also have a corporate social responsibility initiative, which sits in their procurement division. I've included in the next slide their corporate social responsibility initiatives that speak to diversity, equity, and inclusion. I'll read from the second bullet. By celebrating diversity and fostering an inclusive environment, Change Healthcare enriches their team members' experience, broaden their thinking, and increase their ability to innovate and grow in an ever-changing healthcare industry. They recognize that organizations with inclusive cultures are 6 times more likely to be innovative and to anticipate change and respond effectively, and twice as likely to meet or exceed their financial targets. David's going to take us through the performance evaluation to date.
On vendor performance, Change Healthcare has met the majority of vendor performance criteria. One area we see opportunities for continued development relates to the service support staffing. As we have learned through the transformation program, an integrated enterprise solution would require higher level of service support. And whether it's optimization initiative or issue resolution, when it happens, it typically involves all facilities instead of selected locations. And when it happens, more Change Healthcare service support would mean faster turnaround time for issue resolution and a better training experience for our clinical users. Next page, please. And besides seeking enhanced support from our Change Healthcare team, we at Health and Hospital have always proactively driven continuous development through our Radiology Directors Council. So next
I would like to ask Dr. Ambrosino, our co-chair of Radiology Directors Council, to share his perspective of our transformation program.
Thank you, David. I believe that our continuous improvement process has been a key to our success in rolling out a project with the complexity of PACS, which by its very nature require that we integrate it with multiple imaging modalities such as CT and MR, which are complex in their own right, and 3 other major computer systems, namely Epic, sophisticated 3D imaging software packages, and voice recognition systems across all of H&H. Our practice is to understand the clinical needs of each of our facilities across the enterprise to develop a structured and disciplined approach to address identified needs and to identify problems as they appear. We have an ongoing close relationship with EITS, both at the leadership and local levels, supply chain and finance, to the point where we feel like they're actually part of radiology. In addition to our weekly work group meetings, Change attends our monthly steering committee meetings and monthly RDC meetings to provide status reports on progress being made and for them to receive feedback directly from our facilities. As noted in the slide, as we resolve issues, the RDC implements the solution and communicates the resolution at the facility level. I think that the successes that Dr. Garofalo summarized in his earlier slide reflect how effective our approach has been. And just in closing, I'd like to thank the board for the support that we have received through your listening and hearing our needs and providing us with the resources we need to give our patients a cutting-edge care. Thank you.
Thank you, Dr. Next page, please. So, in summary, MMPA and EITS are seeking the approval to enter into a best interest renewal for the agreement with Change Healthcare regarding system license maintenance, program management, and the technological support. The proposed renewal term is 3 years with additional 2 one-year option, and that the cost remains at the same rate from the previous contract. The term of the renewal will be from July 23rd, 2021 through July 22nd, 2026. The renewal cost will be $15 million, $875,000, $46, and including 10% contingency, the total proposed renewal cost will be $17 million, $462,551. Thank you.
Thank you.
Thank you, David.
Thank you.
So, thank you so much. I want to note for the record that Dr. Vincent Calamia had recused himself earlier from this resolution. Thank you. So, any questions from board members? Sally Hernandez-Piñeiro?
I guess we've spent about $23 million almost, and we're going to invest another $17 million. And your best interest renewal argument, I think, is very compelling. But I could see the same argument being made 3 to 5 years from now. I'm wondering if you see anything changing in the landscape that would make you think that there would be more real competition 5 years from now, say?
Yeah,
Talk about technology component.
I can talk a little about that. There was a slide up there that showed the market share, and I was surprised, honestly, by some of the stronger vendors of a few years back that have worn down a little bit, and how Change Health has grown and continues to grow. So in the next 3 years, do I see a change in that in dynamics? Probably not, unless the stronger vendors that turn weaker now begin to do an uphill climb again. But right now, I think Change Health is one of the market leaders. So no, I don't foresee in the next 3 years a process, but only time will tell.
I want to build on that, Sally, because I think you're making an important point that goes beyond this contract, which is that most of us, in a government setting, we think of you bid in order to bring new bidders in, get better pricing, right? And the challenge, I think, that no one has quite figured out is how to think about government technological solutions, right? So let's not think about this for a minute. Let's think about Epic. We can't bid Epic periodically, right? Because we could theoretically, but at a certain point, some of these technologies become sort of part of you, and they're not easy to separate because the amount, I mean, again, just to get off this, to think about Epic, the number of hours that I, as a clinician, have spent learning Epic, right? If you came in and said to me, oh, Mitch, you use Cerner in LA, it's a good product. Sure, Sally, it's a good product, but you're going to make me learn Cerner again? And I mean, again, it may be something that we want to think about as a future. And I don't know that anyone has done good work on, how do you think about technological things that become part of you, right? If you want to change, say, a dietary service, it's a little inconvenient, right? And it may disrupt some relationships, but you move on, right? You don't feel, as David is describing, like what we would do with the images that are on these particular systems. And so I think that it may be something we want to talk about, so that we all have the same expectations going forward with the big technology
I see
grants.
it becomes operationally embedded and embedded in the culture. So I can understand that. And just looking forward, I can see that 5 years from now, we probably will have a best interest renewal exception again, and it would make sense to do it.
If I may add, we, through RDC, continuously monitor the market, and then we invite all the vendors to come to RDC to present the latest technology offerings. Then we always feedback this information to Change Healthcare, so they can always build this to the next development circle. So we're confident with this mechanism through RDC, we'll keep the solution up to date and make it really useful for the clinical users.
Right. I mean, the technology people have to keep up to date, because even if you're not bidding, other people are bidding, right? So that's what keeps the technology fresh. What it doesn't totally deal with is the idea of competition, right? Because that is part of the history of government bidding, is to allow other people to come in. And I'm just not totally sure how you think about contracts that become part of you, and where your costs of extracting the knowledge could become really huge.
I would think at some point the companies themselves that are trying to get into the market provide the data, or are able to provide the data and tell you, hey, you are using this product, but I know it costs to change the product from one to another. Here's some information that you should take into account.
And maybe it's like some advanced, remember, like with switching phones, people would say, okay, if you switch from one phone, we'll make up the difference. It may be that that's what technology companies have to do, is they have to say, if you want to, we recognize that it's 2 years' work.
There are questions from other board members before that happens, though. I thank you so much for providing detailed information on sort of like the cost of how much it would cost H&H to switch this, because that was very helpful.
Yeah, thank you.
And I think Dr. Peña Mora has a question.
Yes, very quickly, again, I think following up on Sally's comment, and particularly if we go to slide, I think I was looking at slide, I don't see the number right now here, the one that, slide 6, where you show that you're looking for vendor neutral archives. I think this type of questions definitely will be important as you're trying to achieve that type of neutral solutions. So I just think that that's a very important discussion to continue having, because as the investment that has been made, you want to ensure that you have the benefits. The other thing that I want to go back to the MWBE and the diversity, and I just want to thank Dr. Allen for her work and her kind of thoroughness of the process to identify not only how this company are able to ensure that there is participation, but also understand more how the company values diversity and the investments that they are making in ensuring that their work really is encompassing beyond of what they normally will do for themselves. So I just want to thank Dr. Allen for really going beyond. This is a very kind of visual case in which you have a company that, because of the technology, tends to have like almost like a closed ecosystem, but at the same time, like any company needs to really be a good citizen and really being able to communicate all they are doing in order to be that good citizen for the communities that they serve. So I just want to thank Dr. Allen for her work and her dedication to ensure that we really communicate our values and really understand how the companies are espousing and practicing some of those values.
Thank you.
Thank you. Dr. Morse?
Yeah, thanks so much. I really appreciate the presentation. And as an internist and hospitalist, the PACs are priceless and gold. So thank you for your work. I was just, I wanted to follow up actually on that same point around diversity and your inclusion efforts. And I'm just so also thankful to see this slide. It is just so important and I appreciate it a ton. And I was hoping that you might be able to follow up with sharing more about the racial and ethnic diversity at the leadership level with your organization, if possible, just because it's just another layer or another frontier, let's say, in diversity and inclusion efforts that it doesn't always come across. And so I was just curious if that could be shared in follow-up.
Will do, Dr. Morris.
Thank you. Any other questions or comments? And I'll just add to it also that the fact that you did the evaluation and found out that they needed to provide better support and include a dedicated support team in this contract, that's it's great to see that. So okay, so let's have a vote on the resolution. Dr. Katz?
Yes.
Dr. Morse?
Yes.
Dr. Harrison?
Yes.
Thank you. Philip Weddle?
Yes.
Phil? Thank you, Phil. Scott French. Barbara Lowe?
Yes, but I just want to say I had a question, just to consider the consumer and what they may be requesting. If at another time we could have a little synopsis of that.
Okay.
Okay.
Thank you. Robert Nolan?
Yes.
Thank you. Sally Hernandez Piñero?
Yes.
Frida Wang? Yeah. Benioski Peña Mora?
Yes.
She was there for a minute.
She was there for a minute.
Yeah, she was.
Yeah.
Anita Kawatra?
Yes.
Thank
Sorry,
you.
I was on mute. I vote yes.
There you
Thank
go.
you.
Thank you. And Jose Pagan, yes, so the resolution has been adopted. Thank you so much. Thank you to the whole team for all the work.
Point of order,
And,
Mr. Chair.
yes, please.
I needed to step out of the meeting after voting on item number 2, action item number 2, to talk to the head of test and tracing. So I see you're up to item number 4. Can I
Yes.
assume that already item number 3 has been approved?
Yes.
Okay, I'd like to vote, if I may, at this time.
Yes,
And
please.
add my vote is yes in support of item number 2. I've read about extensively.
Okay.
So am I allowed to vote afterwards and vote aye? Just have another option if you don't want that.
All right.
If that does, I'm okay?
You reviewed the information
I have.
and you feel like you're
And I
informed
vote
enough to
aye.
make a vote.
Okay, thank you.
Thank you very much.
Okay, so President's report. Dr.
Very
Katz?
good. Thank you. And I'm not going to read it because you have the written version, but there are some highlights. Our chair mentioned the mobile units, and I just want to say what a great thing that is. As someone who's worked on homeless issues, I just thought that Ted's group, Chris Keeley, they did such an amazing job in such a short time of putting together the vans, and so creative to couple giving the vaccine with doing testing and giving people naloxone kits to prevent overdoses and connecting them with services and food, right? It really shows the attempt to meet people where they are and provide something that is meaningful to them. And that on the first day, they gave almost 50 vaccinations. Pretty amazing, right, for something that they, just rolled out. So I thought that was really amazing. We have nearly 2,000 nurses who are participating in the Nurse Clinical Ladder program, with a special shout out to our Chief Nursing Executive, Dr. Natalia Sineas, who's really made the whole professionalization of nursing, has taken it to a new level with us. We got an Innovation Award for Staff Wellness, which we very much appreciate, from the Beryl Institute, which we thought was really great. We're very pleased to have gotten that. The Fan Fox and Leslie R. Samuels Foundation awarded us a $152,000 grant to support palliative care for older adults in the post-acute safety net setting, which I thought was really wonderful. We got from the Aronson Family Foundation a $300,000 grant to support healthcare heroes and their well-being, along with the Centerbridge Foundation, which provided an additional $5,000. So we value our healthcare workers, and we want to take care of them. The simulation symposium this year focused on a question that many of us have struggled with, is how to best address unconscious bias. And I think very creative use of the Simulation Center as a way of doing that. You've heard from other updates about the state budget, and we will continue to update you as we understand how the city's executive budget will fit with our revenues and expenses going forward. And then finally, I issued a declaration of emergency dated March 1, 2020, which we updated and reissued through February 28th, 2021. The question has come up, so I just want to be clear that there's currently no declaration of emergency in effect. The health system has entered into 39 emergency extension agreements with community-based organizations at a total cost among the pool not to exceed $15 million. The costs are being reimbursed by the City of New York. In July 2020, 41 CBOs were selected as an outcome of a solicitation to do COVID-related outreach in high-incidence neighborhoods based on the continuing pandemic, the need to continue community outreach in these neighborhoods. The contracts have been extended through June 30, 2021 for 39 of these CBOs. All were reviewed and were providing satisfactory services prior to our extending their agreements. So thank you so much, Mr. Chair, and thank you to the board for all of their support.
Thank you, Dr. Katz. Any questions from board members for Dr. Katz? Okay,
very good.
Hearing none, then thank you for your report.
Thank you.
So committee and subsidiary reports to the virtual meeting setting. The committee and subsidiary reports were emailed to you for submission into the record. Are there any questions or comments about the reports? Is there any old or new business to come before this board? If there's no further business, I declare the NYC Health and Hospitals Corporation Board meeting adjourned. Thank you so much.
Thank you.
Thank
you.
Thank you.
Madam Council. So is the
If you do a ton of work before the meeting,